My name is Charles Facelis. I am the Assistant Chief of Medicine and Program Director at the VA Medical Center in Washington, D.C. and Associate Professor of Medicine at the George Washington University School of Medicine, and I will be discussing pulmonary medicine with you. The first chapter we will be talking about is the diagnostic tests, things to do to patients to make a diagnosis and follow up on treatment plans, and these are important tests that we will have to know for our USMLE. The first test that I'd like to talk about is the pulmonary function test. Now this is a very important test. Anytime we make a diagnosis on a patient concerning a pulmonary disease, we have to do pulmonary function tests for a couple of reasons that we're going to talk about. There are basically three reasons that we do pulmonary function tests. The first one is to differentiate between the two big different groups of diseases that affect the lung. The restrictive processes, like for example idiopathic pulmonary fibrosis, the pneumoconiosis, the occupational lung diseases like silicosis and asbestosis, they're called pneumoconiosis, and another 150, 200 diseases. All these diseases are called restrictive diseases because they involve the lung parenchyma and they cause restriction of lung volumes. And then we want to differentiate that from the other big group of diseases, the obstructive diseases, like asthma, like chronic obstructive lung disease, emphysema, and chronic bronchitis. So the first reason to do a pulmonary function test is to differentiate between these two groups of diseases. You could see that the differential diagnosis differs when you compare one disease versus the others. So if I'm going to see an obstructive pattern on the pulmonary function test, my differential diagnosis now is going to be, is it asthma? Is it chronic obstructive lung disease? If I see a restrictive pattern on the pulmonary function test, now I'm going to talk about different things. I'm going to say, what is their occupational exposure? Do they have some other type of disease like sarcoidosis, like idiopathic pulmonary fibrosis, totally different from obstructive diseases? The second thing that we do pulmonary function tests for is to assess severity of disease. A lot of patients with chronic lung diseases have to have surgical treatment. For example, a patient with chronic obstructive lung disease is a smoker and develops lung cancer. We cannot resect that lung cancer even if it is surgically resectable unless we prove on the pulmonary function test that the extent of this disease is not severe. So very important, pre-op evaluation of lung disease, pre-existing lung disease, in order to do lung surgery. We have to do pulmonary function tests. And they tell us, for example, we're going to talk about this a little bit later, that certain of the parameters have to be above 50% of predicted. For example, the FEV1 or the FVC has to be above 50% of predicted to be able to do adequate lung surgery in these patients, just to give you an example. And then the third scenario that we do pulmonary function tests is to do post-treatment evaluation. And what I mean by this is that you put a patient on certain medications. I want to bring this patient back about 2 months later. And when I ask them questions, clinical questions, they still complain of dyspnea. They still complain of shortness of breath and so forth. So I'm not going to be able to quantitate the difference in treatment. Did I make a difference? Is this patient getting better? The only way that I could see small differences that are not clinically evident is to do the pulmonary function test. So for example, I put a patient that has idiopathic pulmonary fibrosis on corticosteroids. I bring this patient back 2 months later. Their FEV1, let's say, was 20% of predicted. If this patient is starting to get better on steroids, if the steroid treatment is working, 2-3 months later now, I'll see a difference. I'll see an increase in FEV1, let's say, to 40%, just to give you an example. So those are the three basic reasons to do pulmonary function tests. Diagnose the type of disease, assess the disease severity, and then we said pre-surgical evaluation of lung function. Please, I'll say this later too, but you have to know this, especially with patients that you presume that have some chronic lung disease, especially chronic obstructive lung disease. Please, you have to document that they really have an obstructive disease that's consistent with chronic obstructive lung disease with the pulmonary function tests. One of the things that they've asked on the boards is, well, you think that this patient has COPD, how do you diagnose this patient? This patient has been coming to your clinic for years now. Nobody has documented that this patient has COPD. How do we document that? The answer is we do PFTs, and what do I find on the PFTs? A pattern consistent with COPD. It's not it's not pathognomonic, but it's consistent with it, and we're going to talk about this in a little bit. So when we do pulmonary function tests, when you do full pulmonary function tests, you get different numbers. And on the boards, they may give us, 20, 30 of these parameters, and I only want you to look at the ones that we're going to talk about here. So, first of all, we measure lung volumes. Lung volumes are done under static conditions. What I mean by that is it's not dynamic. It's not, you don't compare it to time. I just measure total volume in a patient, total lung capacity, for example. That volume is under static condition. It doesn't tell me what this patient does, how the patient moves air in and out of the lung. That's very important that you understand that. So lung volumes are measured under static conditions, stable condition. I don't know what's going on with time. I don't know how they move air in and out of their lung. I only know if they're normal, increased, or decreased. That's all I know. Because it only allows for measurement of lung volumes under static conditions, the diseases that they really point to are the restrictive lung diseases. So for example, if a patient has silicosis, or let's say they have asbestosis, they get an inflammatory process that affects the lung parenchyma, and as the inflammatory process increases, you get fibrosis and scarring of the lung, and their lung volumes shorten. They get decreased. They get restricted. So if I'm thinking about a restrictive disease, when I measure my lung volumes, they will be decreased. That's what I'm looking for. Now, I said they point towards restrictive diseases. Really, the reason you're doing them is to confirm that this patient has a restrictive disease. But there's also a clinical pearl that I'm going to talk about a little bit later. In patients with obstructive disease, they're usually normal, or they could be elevated. So, for example, they're above normal. Instead of having 100% of predicted, these patients have 120% of predicted of lung volumes. And why does that occur? Because patients with obstructive disease, if you remember, take a patient with asthma, they blow out air and their airways collapse and they trap air into their lung, right, into their lung volumes. So their total lung capacity is increased, their residual volume is increased. This is what we see on the chest x-ray with the flattened diaphragms, the big hyperinflated lungs. So really, lung volumes, when we measure them, I'm really looking for restrictive lung disease, but a lot of times when they're supernormal, above normal, they give us information and they point towards obstructive diseases. I want people to understand that. So let's look at the three most important things. These are the three lung volumes you have to know. And nothing more. We're going to talk about dynamic volumes a little bit later. But when we talk about the pulmonary indices, the pulmonary volumes, I want you to know only three lung volumes. And they're easy to remember. The first one is total lung capacity, or TLC. We have to remember that a little bit later because you're going to see this on the graph, on the table. But total lung capacity is, if I don't know if anybody has looked at patients doing pulmonary function tests, but we make them, sit in a room and they're breathing air, and the tech tells them, breathe in air, breathe in air, breathe in air until they can't breathe anymore. So they take a maximum inspiration. That's what they start off with, taking a maximum inspiration, and you always hear the techs yelling, say, you know, breathe in more, and then once they start to breathe in more and they can't breathe in anymore, when you measure that lung volume in the lung after maximum inspiration, take the deepest inspiration you could take, right? And now I'm measuring lung volume in the lung after a maximum inspiration. That is called total lung capacity. And then, once I have that, what the tech does is it tells the patient to breathe out all the way. Breathe out, breathe out, breathe out, breathe out all the way, expel all the air out of their lungs. And then they do one of a couple of things depending on the way they're doing their pulmonary function test. They either measure the amount of air that they just expelled, or they measure what's left in the lung. And if you think about it, if total lung capacity is the amount of air after maximum inspiration, what's the amount of air that's left in the lung after a maximum expiration, right? So they breathe out all the air out of their lungs, maximum expiration. What's left in the lung is what we can expel. This is called residual volume. So what's left in the lung after maximum expiration? Residual volume. What did you breathe out? It's called vital capacity. That's all we need to know. Those are the three volumes that we need to know to basically diagnose our pulmonary function tests on the boards. The amount of air in the lung after maximum inspiration, total lung capacity, the amount of air you breathe out of your lung after maximum expiration, that's vital capacity. And what do you have in the lung after maximum expiration? Residual volume. End of story. And look at this. If you go on to this figure now, look at this. You know, they give us all these lung volumes, and we also put the other stuff that they could put there for you and kind of mix you up, inspiratory capacity, tidal volume, and stuff like that. I don't want you to know stuff like that. I told you, I only want you to know these three volumes. So here it is. This is the maximum inspiration here, total lung capacity, right here, right? And then remember what you did? You expelled all the air out of your lung, and what are you left with? The residual volume. And what did you expel out of your lung with a maximum expiration? The vital capacity. Here it is right here. Now, you know, if you remember part one, and sometimes they ask us this in part two, they tell us, well, you know, what's total lung capacity? Well, it's a combination of vital capacity and residual volume, right? That's what they may ask us. They also, people get all concerned, and we're going to talk about this a little bit later, about what's normal. What's normal? What are these volumes? You know, what's normal for these volumes? And the answer is, for all pulmonary function tests, whether we talk about lung volumes or volumes under dynamic conditions, we're going to talk about this a little bit later, or anything else, it's all percent of predicted. Let me give you an example. 80% predicted and above is considered normal. Anything below 80% predicted of the normal population is abnormal. They don't usually give us, you know, things close to normal. They give us something like, for example, 50% of predicted or 40% of predicted. So if they're going to give you numbers that really are low, and to make you understand that you're talking about an abnormal number for total lung capacity or vital capacity or residual volume. They may also tell us, look, it's not 80% of predicted, right, or 50% of predicted, it's 0.50. Well, that's the same thing. They're talking about 0.5 of, you know, total, you know, of you know, 1. That's the maximum. So think about percent of predicted when they're talking about any type of pulmonary function test, and anything above 80% of predicted is considered normal. Anything above 100% of predicted is considered supranormal, right? And that's when we start to think about these things called obstructive lung diseases. So that's number one. That's the first part of the pulmonary function test that we have to know about, the lung volumes under static condition. And then they do a second part of the pulmonary function test. And now, remember when the patient was blowing air out of their lungs? And we said the patient breathes in totally, right? As much as they could breathe in. And now we make them expel all the air out. And that was called vital capacity, right? Well, if you measure vital capacity and you plot it against time, then I get a sense of how this patient moves air in and out of the lung now. Now it's under dynamic conditions. I did it under static conditions before because I got total vital capacity, right? I didn't know how they did it, but I got the total vital capacity. But now I want to know, well, how does this patient move air in and out of the lung? And I take vital capacity, and what I do is I plot it against time. And now it's the same thing, but now it's called forced vital capacity. Whenever you hear anything about forced volumes, forced flow, expiratory flow, all these parameters are measured against time, and they give you a sense of air movement in and out of the lung under dynamic conditions now. They're telling you, how does this patient move air in and out of the lung? And now, if we take a part of vital capacity, which we now just called forced vital capacity, and we take the first second, I'm going to show you that in a little bit, right, of part of vital capacity, it's called forced expiratory volume, 1 second. So that part of vital capacity at 1 second, it's called forced expiratory volume at 1 second. And if you plot that ratio, FEV1, forced expiratory volume at 1 second, over the vital capacity, which we now call forced vital capacity, that ratio, FEV1 over FVC, is the best measure of airflow in the lung. And what does it tell us about which diseases have a problem with getting rid of air out of their lung? The answer is the obstructive diseases. The patient with asthma, the patient with chronic bronchitis, what happens when they blow out air out of their lung, their airways collapse and they trap air in the lung and they can't get rid of it, right? They can't move air in and out of their lungs. So these forced expiratory flows, these forced expiratory volumes are just part of vital capacity, but we measure it against time. And I just told you that ratio of FEV1 over FVC is the best measure of this. And it tells us about obstructive diseases. So let me show you why it's so important. Because if you look at here, if you look at the middle graph here, if you look at the middle graph where it's an obstructive pattern, right here, look at this. A patient with an obstructive pattern, they blow air out of their lung. Now look at this. They can't blow air out of their lung. Look, 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 look. Compare this compared to the slope of the curve right here. In a normal patient, look at a normal patient. They blow air out of their lung. They go boom. They expel most of the air right away, right in that first second. A patient with chronic obstructive lung disease, that first 1 second is when the airways collapse, and look what they're doing. Their FEV1 is decreased, you know, and that's the biggest decrease in that 1 second that you see with obstructive disease. That's the biggest decrease in air movement. And when you plot that over FVC, that's the big abnormal ratio that you get. Now you're going to say to me, and they've asked this question on the boards, you're going to say, wait a second, how about restrictive diseases? Look at the one right here, all the way to your right, the restrictive diseases. How about them? Doesn't a patient with pneumoconiosis, don't they have a decreased FEV1? Don't they have a decreased FVC? They do. But both are decreased at the same time, equally. So a patient that has pneumoconiosis, idiopathic pulmonary fibrosis, they have a decrease in FEV1 and FVC in the same ratio. Remember, this is the ratio of FEV1 over FVC. So that relationship is equally decreased. So overall, you don't see a difference when you compare that ratio. When you look at obstructive disease, it's the FEV1 that gets decreased much more than the FVC. So I need everybody to understand that the FEV1 over FVC is the best measure of airflow in the lung, and it diagnoses obstructive disease. Now, one more thing, I'm going to tell you another clinical pearl here that we're going to talk about a little bit later also. there's, if you go back here, and you measure the slope of the curve here, see what I'm looking at with the arrow? The slope of the curve in an obstructive pattern, right? The slope of the curve here is between 25% right here and 75% of predicted, right? That's the slope of the curve there. And that is sometimes called the forced expiratory flow 2575, or FEF 2575. They're telling you that it's part of FVC, it's the slope of the curve, and it's between 25 and 75% of your FVC. Basically, what I want you to know is that this is another way to measure obstructive diseases. So we have two ways to measure obstructive diseases. The FEV1 over FEC, and then the other one that I just told you about, the slope of the curve of the FVC, is called the FEF 2575. For the purposes of the boards, either one of these is abnormal, either one. They're usually both abnormal, but either one is abnormal, which means less than 80% of predicted. That patient has some type of obstructive disease. In clinical practice, we commonly will see patients with normal or near normal FEV1s over FECs, but they have early disease. So it doesn't pick it up. That ratio doesn't pick it up yet. And then you look at your FEF 2575, and that's going to be decreased. So really, the FEF 2575, clinicians use that to pick up early obstructive disease. Sometimes in some of the older textbooks, you're going to hear the term small airway obstruction disease. It really refers to some type of obstructive disease that's early, that hasn't really manifested, severely, so you don't have a decrease in FEV1 over FEC. For our purpose, either one of these is abnormal. It points towards an obstructive disease. Either one of these, it doesn't matter. So again, forced expiratory volumes are the second part of the pulmonary function test. Why do we do it? To measure volumes and flow under dynamic conditions. What does it give us information about? It tells us about obstructive diseases. What are the indices we look at? We look at the FEV1 over FEC, and we look at the FEF 2575. Both of those are the same thing virtually. So bottom line, restrictive disease will have a low total lung capacity, low residual volume, and low vital capacity. These are the static volumes. And if you measure FEV1 over FEC, because the ratios of those are equally decreased, the ratio remains the same, the volumes are equally decreased, I should say, the FEV1 over FEC is normal. So restrictive disease has low total lung capacity, low residual volume, low vital capacity, normal FEV1 over FEC, and normal FEF 2575. If you look at patients with obstructive disease, asthma, chronic bronchitis, emphysema, you find typically a low FEV1 over FEC, and you remember why that is, because your FEV1 really drops right away. That's the vital capacity at 1 second, and it's called forced expiratory volume at 1 second. And when you put that ratio together, it gives you the best measure of obstruction, and that's low. And we also look at the FEF 2575, that's also decreased. Now, I told you either one of these is good enough to diagnose obstructive disease, either one. Plus, we have some other things that point towards this indirectly. For example, because patients with obstructive disease have air trapping, when I look at their residual volume, it's going to be elevated. 110% of predicted, 120% of predicted, and their total lung capacity is elevated because they trap air in the lungs. So the sign of an obstructive disease on the PFTs is a low FEV1 over FEC, low FEF 2575, and an elevated residual volume, maybe an elevated total lung capacity. We said overall, when you compare all these tests, It's easy to remember because anything less than 80% of predicted, 0.8, is considered abnormal. That's all you have to remember. The third part of the pulmonary function test is to determine lung diffusion and really how well oxygen passes through the alveolar space and into the pulmonary vessels. So what you're really looking for when you do this test, the third part of the pulmonary function test, you're really seeing is there anything wrong with the alveolar membrane? Is there anything wrong with gas exchange? And this test is called the diffusing lung capacity of carbon monoxide, because you're really using a little bit of carbon monoxide to see if there's anything wrong with diffusion across the alveolar membrane. This is also referred to as the DLCO. This is an important test, and if you look at this figure here, it illustrates what kind of information we get from this test. So go here, look at the alveolar membrane here, right? Now remember, we're giving this patient carbon monoxide, and we're measuring, does it diffuse well across this alveolar membrane here into the pulmonary vasculature. Now look at this. If a patient has interstitial lung disease, right, so they have intrapulmonary restrictive disease, let's say this patient has asbestosis. Look at that. This patient has inflammation of the alveoli, right, and eventually this leads to fibrosis here. So look at this. The diffusing capacity in this patient will be decreased. On the other hand, a patient with clear-cut emphysema, remember the definition of emphysema, we're going to talk about this in a little bit, is the permanent dilatation of the alveolar membrane. Destruction and dilatation of the alveolar membrane. And look at this. This patient's alveoli here from smoking is destroyed, right? Inflamed and then destroyed. So the diffusing capacity here is also decreased, right? So this test, the DLCO, gives us information just about oxygen diffusing capacity. We use carbon monoxide, but it's really telling us about oxygen diffusing capacity. It doesn't diagnose a disease itself, but when you combine it with the rest of the pulmonary function tests, it gives us a diagnosis of one disease versus the other. So let me explain this. If I have a patient with obstructive lung disease, my pulmonary function tests are going to look the same whether I'm talking about chronic bronchitis, emphysema, or asthma. They look exactly the same. How do I know this patient has emphysema? I do the DLCO, and I find it decreased because I know it's only emphysema that causes a destruction of the alveolar membrane. If a patient has clear-cut chronic bronchitis, or asthma, there's nothing wrong with the DLCO, with the diffusing capacity across the alveolar membrane. That is normal. If a patient with interstitial lung disease develops a restrictive pattern, I confirm this by finding a low DLCO. It tells me that this is intrapulmonary restriction, because there's also other types of restriction. We could have an extrapulmonary restrictive process. For example, a patient has myasthenia gravis or Guillain-Barré syndrome, neuromuscular problems, and they can't breathe well, so they have extrapulmonary restriction. Or they have morbid obesity, so their lung expansion decreases, is restricted. Things like that. Or kyphoscoliosis, that's probably the most important one that we see in clinical practice. So there are ways to restrict the lung that doesn't involving the lung parenchyma. I wouldn't know that unless I did the DLCO, because the pulmonary function tests in both of these, whether I'm talking about asbestosis or I'm talking about somebody with myasthenia gravis, they would be exactly the same. But then I look at my DLCO here, and what do I find? I find that my DLCO is decreased. That's consistent with intrapulmonary restriction. If I find the DLCO normal, then I start to think about diseases outside the lung that could cause a restrictive process. The basic three that I just talked about: kyphoscoliosis, morbid obesity, right, and neuromuscular disease. So let's summarize all that, and let's look at a couple of scenarios. So the bottom line is the DLCO is decreased in emphysema and interstitial lung disease intrapulmonary restriction, and it's normal in chronic bronchitis and extrapulmonary restriction. And I gave you the 3 examples of that. Those are very important because really they ask us on the boards because it's probably the most common form of restrictive lung disease that we see, extrapulmonary restriction, usually due to kyphoscoliosis. And then I put one more in here in case they ask you. They haven't asked this yet, but it is a common thing that people know. If you have alveolar hemorrhage in the lung, if you have hemorrhage in the lung and you measure the DLCO, because there's a lot of red cells there, the DLCO will be increased. So DLCO is decreased in anything that affects the alveolar membrane and is increased with alveolar hemorrhage. So think about things that could cause alveolar hemorrhage. Goodpasture syndrome, lupus, Wegener's disease, right? So things that affect the lung and cause pulmonary hemorrhage. So think about that. And then we want to take a look at a couple of other tests before we do our problems. And let me just tell you just a few of them. They're simple tests, but that you need to know them for the boards. So the basic 3 we talked about is the static volumes. Then we talked about the dynamic conditions, the FEV1 over FVC. And then the third one, we talked about the DLCO. Those are your basic 3 tests. And then we have some other tests that we may or may not do depending on the case. So let me tell you a little bit about these. The first one that's very important is this thing called the methacholine challenge test. Now, methacholine challenge, when you give patients methacholine, no matter who the patient is, they get bronchoconstriction, even normal patients. It bronchoprovokes, it causes bronchoconstriction, it causes reaction of the bronchi. It causes like a mini asthmatic attack. In normal people, they feel they get a little bit of cough, they get a little bit of congestion, even normal people. Asthmatic patients, though, because they already are predisposed to reactive airways, their airways are a little bit reactive. Once you give them methacholine challenge, you're causing them a mini asthmatic attack. And you can measure that on the pulmonary function test. Now, think about this. It's only when you're considering the diagnosis of asthma. You shouldn't be doing methacholine challenge tests in people with restrictive lung disease. It has no purpose there. And really the reason you're doing it when you're considering patients that have asthma is because a patient with asthma, you could do the pulmonary function test and it could be totally normal. Remember, asthma is a reversible condition, totally reversible. We're going to talk about that a little bit later, but it's a totally reversible condition. So in fact, you could do somebody that says, yeah, I go out in the cold and I get cough and I get wheezing, and you could do a pulmonary function test on that person because they're feeling well, because the asthmatic attack has gone away, and what you're going to get is a normal pulmonary function test in this patient. So you can't diagnose asthma in this patient. What do? You do the methacholine challenge. And if you give this patient methacholine challenge, you see that now you come back and you redo the pulmonary function test, and now you see an obstructive pattern typical of asthma that's reversible. Now, I said a positive test, you could have bronchoconstriction even in a normal person, but in these patients, it's a big drop. So, for example, you'll see that the FEV1 over FVC was, let's say, 85% of predicted, and now you do the methacholine challenge test, and now this patient goes down to 50% of predicted. So a change of, 35+%. That's the kind of drop you see to make the diagnosis. So the positive test in methacholine challenge means at least drop of 20% of predicted. You go from 80 to 60. The patient I just gave you went from 85 or something like that to, 60 or something like that, or 50. So big change. Anything 20% or above is a positive test. If you see somebody that has 5–6% with a methacholine challenge test, no. This is usually a normal patient. That's you and I that did the methacholine challenge test and developed a little bit of hyperactivity because the methacholine challenge does that. Now, a couple more things about this test. It should be done under a controlled environment. And why do I say this? Because there's been reported cases, much celebrated cases, one last one under a research protocol in a big institution where they gave this woman methacholine challenge and she developed status asthmaticus and died because there was nobody around her to help her. So it has a potential not only to cause a mini asthmatic attack in patients, but sometimes to go overboard and cause a status asthmaticus. So you have to have this patient in a good control environment in case something like that happens. You can't do this in your office, and not pay attention to this patient. So the methacholine challenge test should be done under conditions where you could reverse bronchoconstriction if this occurs, severity occurs. In some institutions, methacholine challenge for this reason is hard to get. So they have to order it, specifically, and then say why they order it and prove that they're doing it under controlled setting and so forth. Another way that you could do a bronchoprovocation test is not give the patient methacholine challenge, but take them out in the cold weather, and they come back. It's interesting because that's what they do in some places. They don't have methacholine challenge, so they take the patient out, they make them exercise around the block a couple times in the cold, and they come back, and you see the pulmonary function test, it was normal, and now all of a sudden it's dropped by 30%. Same concept there. The second other test that I want you to know is this thing called bronchodilator reversibility. And this is very important because once a patient develops obstructive disease, the only way that we could tell the difference between asthma, which is 100% reversible disease, and chronic obstructive lung disease, which is by definition non-reversible, the only way we could tell the difference is by giving this patient a bronchodilator, like albuterol, and then see on the pulmonary function test, is it reversible? If it's reversible, it's asthma. If it's not reversible, then it's likely chronic obstructive lung disease. And what I mean by non-reversible, you may see a little bit of reversibility, 2, 3, 4, 5%, but it's not the dramatic reversibility that you see in asthma. So for example, I do a pulmonary function test on the patient, and I get an obstructive pattern. I don't know if it's chronic obstructive lung disease versus asthma. What do? I give the patient a little bit of albuterol. I repeat this test again, and now I see it's reversed by 30%. What's my diagnosis? Asthma. Versus, I do the bronchodilator, and now I don't see any reversibility. I'll see 4% reversibility. That's minimal. I say this patient has chronic obstructive lung disease. And that's how I make my diagnosis. So let's go back and do a couple of cases to make sure everybody understands what exactly we just talked about all this time about pulmonary function testing. So they like to ask us questions on the boards about this, and again, just focus on the parameters and the volumes that we just talked about. So let's take patient number 1 right here, patient number 1, and then we'll break down to 2 possibility. Patient number 1, the first thing we look at, they give us, is that the patient has a total lung capacity of 87% of predicted, right? They may give us 0.87, it's fine, we know what that means. And then the residual volume is 120% of predicted, and I told you right away, that should clue you into something, because usually a very high residual volume is seen sometimes in obstructive diseases, right, because of the air trapping. The vital capacity is pretty normal. So total lung capacity looks okay. The vital capacity looks okay. The FEV1 over FEC, I told you anything below 80, and this patient, if you notice here, has 80% of predictors. I say, hey, that's probably a little bit normal, right? And then, well, what does this patient have? Then I have one more thing to look at. I look at the FEF 2575 right here, forced expiratory flow between 25 and 75% of what? Of vital capacity, right? That's what they're talking about. This is decreased. So right away I look at somebody that has normal everything except a high residual volume, right? That points towards obstructive disease. And then I look at my FEF 2575, that's decreased. That diagnoses obstructive disease. If you want to be a purist, fine. You could say this patient has small airways disease, early COPD or something like that. I don't care, but this patient has obstructive disease. Now, I need to take a look at one third thing, the DLCO. Remember we said that's the third part. And I look at patient 1A, that's the first possibility, 90% of predicted. So this patient has an obstructive pattern with 90% predicted. That's a normal DLCO. And I say to myself, that is asthma, because nothing else could cause a normal DLCO except asthma. But I told you also there's a possibility that if the patient has pure chronic bronchitis, the DLCO could also be normal. I went for asthma first because that's the typical one. But for the boards, a patient with clear-cut only chronic bronchitis will have a normal DLCO. So I can't, how do I know the difference between these two? I do a bronchodilator test to see which one is reversible and which one is not. So my diagnosis here for patient 1A is asthma, more likely than not. And then if that's not the case, it's chronic bronchitis. Clinically, patients with chronic bronchitis have a little bit of emphysema, so we don't see usually a normal DLCO. But for the boards, I told you chronic bronchitis may have a normal DLCO. I can't tell the difference. I have to do a bronchodilator test to tell the difference between asthma and chronic bronchitis. So patient 1A, it's asthma versus chronic bronchitis. Patient 1B, right here, look at this. This could only be one thing. What is the obstructive disease that has a problem with oxygen going through the alveoli? And we said there's only one, and that's emphysema. So a patient with an obstructive pattern and a low DLCO, 40% of predicted right here, this patient has emphysema. End of story. Let's go to patient number 2. This patient has total lung capacity, 55% of predicted, that's low. Residual volume, 50% of predicted, that's also low. 50% of predicted vital capacity, that's also decreased. So far, I'm looking at somebody with likely a restrictive pattern because these static volumes are decreased. And then I check the FEV1 over FVC and the FEF 2575 to confirm this. And what do I find? I find that these are normal. These are normal. Remember, these are ratios of one volume to the other against time, and these are normal because they're all equally decreased at the same event, at the same time, in patients with restrictive disease. That's why they look normal. So I have a restrictive disease. And then I look at my DLCO, and patient 2A, right here, 2A, I find that this patient has a DLCO that is 90% of predicted, which means that this patient's diffusing capacity in the lung is normal. So what type of patient has a restrictive pattern with a normal diffusing capacity across the alveolar membrane? Well, it ain't intrapulmonary disease. This is called extrapulmonary restrictive disease. And I gave you 3 examples of that. The most known one, the one that we see in clinical practice more frequently, is people with kyphoscoliosis, severe kyphoscoliosis, usually older patients. If they have severe kyphoscoliosis, it causes a restrictive pattern in the lung, extrapulmonary restriction. Then we talked about morbid obesity. People with morbid obesity may have that. And then the third one that they've tested on the board sometime is neuromuscular disease. So say a patient with Guillain-Barré syndrome or ALS or myasthenia gravis, they develop weakness of the thoracic muscle so they can't expand their lungs, and their lungs is restricted. But their diffusing capacity is normal because there's nothing affecting the alveolar membrane. So please remember that. Patient 2A is very important, extrapulmonary restriction. They have a restrictive pattern plus a normal DLCO. And patient 2B is the typical restrictive pattern patient right here, right, where we look at here and look at this, 40% of predicted, that's really low. So this patient has intrapulmonary disease. intrapulmonary restriction, right? So if they give us examples and they say, you know, combine this pulmonary function test with the appropriate disease, your answer would be it's something in the lung, right? Like idiopathic pulmonary fibrosis, like pneumoconiosis, any one of these, 300 diseases that affect the lung and the alveoli membrane. Very good. So that's the end of the pulmonary function test questions, but sometimes they go one step further on the boards and they like to show us these things called flow volume loops. Now, flow volume loops are very interesting because these things express a relationship between the flow rates, how air moves in the lung, versus the lung volumes in different lung processes. They're very interesting because it's done really under dynamic conditions where the patient moves air in and out of the lung, expiratory, inspiratory phase. I'm going to show you in a little bit, and they tell us, well, what does this look like? And I'm going to explain the whole thing to you. But as we go and we talk about the different diseases, I want you to definitely know 3 types of patterns for the boards. I want you to know the obstructive pattern. We definitely need to know that because it has a characteristic finding on the flow volume loop. Then I want you to know just the way a fixed airway obstruction looks. It looks like a box because it's fixed. You can't move air. You can move certain air, and then you can't expel air at the same time. It looks like basically like a square box, and this is typical of things that like tracheal stenosis. So they have somebody intubated for a long time and they develop tracheal stenosis. So they can't get air in the lung, they can't get air out of the lung, they minimal air in and out of the lung. And it looks like a box. And then sometimes they've asked, not so much in step 2, but they've asked about a dynamic obstruction. This is like, it works like a ball and valve mechanism where this patient has vocal cord paralysis, and now under those conditions you see a half a box on top and then a normal curve on the bottom, or the opposite, a normal curve on top and a flattened box on the bottom, and I'll show you those in a little bit. So flow volume loops are very interesting, and let's go because you got to know a couple things about this. Now look at this. It tells us about the expiratory phase here, right? It tells us about the expiratory phase, how air moves in the lung during the expiratory phase and the inspiratory phase. So on the top you have expiration, on the bottom you have inspiration, and here's the interesting thing. Look at this now. Volume in the lung increases from right to left. From right to left. That's the interesting thing. That's what you have to remember, because otherwise you don't remember how these things work. Now if you look at this, if you look at this graph here, if you go to the end of the inspiration, right? Now you're measuring volume in the lung now, right? You're measuring volume in the lung. So at the end of your inspiration, you have maximum volume of air in the lung. What's the maximum amount of air you have in the lung at the end of inspiration? It's called total lung capacity, right? This is it right here, see? And then you tell the patient, okay, blow out air now, blow out air, maximally, okay, go all the way out, and you go down to here. You see, you don't go down to 0. You don't go down to 0, you go down to some number, like 1.5, 2, right? Because you still have air in your lung, right? What's this part here? What's this? This is residual volume here. Remember, you're measuring air in and out of the lung, the air you move. This is residual volume. You never go down to 0. You can't get rid of all the air in your lung, right? You always have residual volume. So that's a normal curve. So it goes like, okay, you tell the patient, breathe again. You go up to total lung capacity. Breathe out. You see a sharp jump because you expel air quickly. Remember when we were looking at the FEV1s? You expel, a normal patient expels air really quick, and then up you get this, kind of downslope phase, and it goes down to residual volume. That's a normal curve. Now look what happens to an obstructive pattern. Look at this patient. You tell this patient to expel right? And look what happens. You get this thing here, right? And then the air gets trapped because the airways collapse. And look at this. You notice, look at the arrow here. You notice this prolonged, scalloped phase of expiration right here, like this, kind of tapers off, right? Because there's air trapping, so the patient can't get air out of the lung. And what you also notice is, now it's not greatly evident in this figure here, but I want you to know this. When you look at this patient's, when they go down to their residual volume, look at here, it's higher than a normal person. It should be higher. Now this graph, you can't see it because they all end in kind of the same place, but a patient with obstructive disease should end right around here, right? Right around here, because it's higher than a normal patient's, because they have more air trapping, they have more residual volume in their lung. And sometimes they even help you out because they shift this curve all the way to the left. I'm going to show you another example in a little bit where it's more evident. They shift this curve all the way to the left because these patients actually, when they have inspiration, their total lung capacity goes up too, because they trap air in the lung again that way. So to make a long story short, an obstructive pattern is something that you have this prolonged phase here, like this, prolonged and kind of scalloped phase in the expiratory phase. The residual volume is elevated compared to a normal patient, and sometimes the total lung capacity, so it's shifted to the left, usually. You don't see it here, because not all patients do that. So, but I want you to know those are the three typical features of an obstructive pattern. We're going to see this again in a little bit. And then the second one I want you to know that's very important. Now look at this patient. Now this is a fixed obstruction here. See this? It looks kind of like a box. See? This patient has tracheal stenosis, right? Look at that. They can't move air in and out of the lung. It's like a fixed obstruction, both in and out. So that patient has fixed obstruction, tracheal stenosis, or foreign body, or something like that, or mass there, something that they can't get air in, they can't get air out. Now some people, remember we talked about the vocal cord paralysis patient? They will have, a fixed obstruction because it works like a ball and valve mechanism, so they may have a fixed obstruction here, so you have same thing here, but then the bottom part looks normal, kind of like this. Or the opposite of that. That's a dynamic obstruction. And the typical one is a vocal cord paralysis. I want you to know that one too. So let's look at another flow volume loop. I want you to compare now a restrictive pattern and obstructive pattern. Now look at this. This is a little bit more, it looks a little bit better in terms of what we just talked about. So look at this. Look at the normal patient here. This patient, you tell them, okay, take a deep breath, right? They go up to their, take a deep breath, they go up to their total lung capacity, right there. And then you tell them blow out, and you get the sharp, air of gushing out of the lung, and then, a quick taper off. And it goes down to, never goes down to zero, it goes down to their residual volume, right there. Okay? Take a patient, though, that has the typical obstructive pattern, and what do you notice? One, you notice right away that this patient's curve right here, this is the obstructive pattern, O, is shifted to the left. You notice that the residual volume here is elevated compared to the normal patient. Look at this delta here, right? Shifted to the left. Their total lung capacity is shifted to the left. So the whole curve is shifted to the left. Why is that? Because of the air trapping, the flattened diaphragms, the hyperinflated lungs that we see on the chest x-ray. This is what you see, what you're really getting a sense of on the flow volume loop. So anything shifted to the left of a normal flow volume loop, especially with an elevated residual volume, that patient likely has some type of obstructive disease. And the third one that I want you to know about the obstructive disease is, look at this. You look at this expiratory phase, right? You see this this kind of more, you don't see a sharp expiration, right? And now the airways collapse, and what do you get? You know, you peak early because your airways collapse, and what do you get? Now you get this prolonged here scalloped phase in expiration, right here where the arrow is. Compare that, it's probably more prolonged. It should be more prolonged than what we're showing on the graph here. So that's the typical obstructive disease that you see. Compare that to the normal one, and you see a big difference. So what are the three typical things that we see with obstructive disease? Right, the prolonged expiratory phase, the scalloped phase, the increased residual volume, right, and the total lung capacity increase too. That's the shifting of the curve to the left. Anything that shifts to the left of a normal curve, that patient has obstructive disease. Now, they've asked this in some of the step 3 tests. Now, we haven't seen it in step 2, but look at this. If I were to figure out, how do I figure out if this patient with obstructive disease here has an obstructive disease that's non-reversible, like chronic bronchitis, versus a disease that's reversible, like asthma? And what do I do to this patient? Well, what did we do before? We gave him bronchodilator. And then a patient that has asthma, you see a shift of this curve here, right here, towards normal. You start to normalize. You start to get like this, like the normal curve. We don't show it here, but it starts to shift and become more and more normal. So a response to bronchodilator of this pattern, the obstructive pattern here, means that this patient has asthma. If you see just a very small change or no change at all, that patient has chronic bronchitis. End of story. Compare this now to restrictive disease. Now look at this. Restrictive disease is all the way to your right. Right? Because, why? Because if you compare the volumes of a patient with restrictive disease, the residual volume is decreased. Remember, their lungs are restricted, right? They're small. Their residual volume is small, decreased. Their total lung capacity right here is decreased compared to the normal one, right? And the whole curve itself is decreased because they can't contain, volumes of lung in their lung because their lung fields are small. Their lung volumes are small. So any curve shifted to the right of a normal curve, right, like our patient here with R, restrictive, anything shifted to the right of a normal curve, that patient has a restrictive disease. Confirm that by looking at the residual volume. Here it is. It's decreased compared to a normal one. And the total lung capacity, that's decreased compared to the normal one. Any shifting of the curve to the right, restrictive pattern, any shifting of the left to the left of a normal curve, obstructive pattern, give the patient bronchodilator, see if they react to tell the difference between asthma and chronic obstructive lung disease. And that concludes the diagnostic tests.